All right. Well, good afternoon, at least to the folks on the East Coast. Good morning to everyone else in America. This is Brandon Garrett, and it's Friday, so we're going to do have a good webinar session for you. Today's webinar is going to be data equity, promoting data education and research to improve access to care. We'll start in 1 minute. I just want to have a couple of announcements before introducing our moderator, Courtney Lang. As you all know, NMQF does an annual summit on health disparities. This summit will take place April 28th and 29th in Washington, D.C. at the Conrad Hotel, and we put information about registering for the summit. And also, if you have an interest or know anyone that is interested in being one of our top 40 under 40 leaders in health, the applications are going through March 7th. And so we encourage you to have them apply or you to apply yourself. And I'm going to also introduce Courtney Lang, who's going to moderate this panel. This isn't her first time doing this. She's done this a few of the time, especially in this data equity space. You've seen the bio on her and all that, but I just want to highlight a couple of things about Courtney. She's been working with us at NMKF since near the beginning of the organization. And last year we gave her award as our outstanding leader because of the work she does in the healthcare, health equity, health whatever space. And so without further ado, I'm going to turn it over to somebody who's much better in this space than I am, Courtney Lang.
Thank you so much, Brandon, for your very generous introduction, and welcome everyone. I want to extend a special thank you and gratitude to Dr. Gary Puckrin, who has long been a data equity advocate since the inception of the National Minority Quality Forum. So Dr. Puckrin, we owe you just complete appreciation for your steadfast commitment to this space. I will be introducing our panel, starting with Gretchen Wortman, who is leading the Institute for Policy and Practice at the National Minority Quality Forum. She serves as vice president there. Aishat Magbade, who is with Blue Cross Blue Shield Association. She has been a tremendous policy presence and will be highlighting some really key provisions of SPD 15. Jenny Haley with the Urban Institute, another data equity champion, and Guadalupe Pacheco with the National Hispanic Health Foundation. Their complete biographies are also available via the NMQF website and will be visualized as a part of the YouTube link following this session. So welcome everyone. During this time where you see a lot of retraction in the space, I want to acknowledge the work of Blue Cross Blue Shield Association coming together with the National Minority Quality Forum, leaning in and not pulling out. And so we are here with data equity, promoting data education and research to advance and improve access to care. Thank you. And so Gretchen, I am going to turn the floor over to you to bring greetings on behalf of the Data Equity Coalition.
Thank you, Courtney. And good afternoon, everyone. My name is Gretchen Wortman. I am Vice President for Policy and Program of the National Minority Quality Forum. And as Courtney referenced, I also direct our Institute for Equity in Health Policy and Practice. On behalf of Dr. Puckrin and the entire NMQF team, I want to thank Blue Cross Blue Shield Association for their vision and leadership in enabling the creation of the Data Equity Coalition. And although she could not be with us today, I must also recognize the leadership of Ms. Keisha Brooks-Colley, whose leadership is, for want of a better term, unflappable and stalwart in the work that we've been doing over the past few years. She's a role model for me, and I think for all of us as we think about the sort of a template we can follow in providing consistent, stable leadership in increasingly destabilizing times. Courtney, I also want to thank, as she knows, and I know, she always takes the call and she always has an answer. And that's invaluable as we So represent our organizations in what are proving to be risky times. The Data Equity Coalition, which is jointly sponsored by NMQF and BCBSA, has proven to be an invaluable forum that facilitates the identification of opportunities to help assure that data are collected that enable all of us to be visible, to be seen, and to help assure that the health services research, delivery, and financing system takes our needs into account and can be held accountable for their action and inaction. You will hear more today about the work we have done on OMB Statistical Policy Directive 15, which was our first joint venture. NMQF looks forward to more in the next few years. And with that, Courtney, I return the mic to you.
Thank you so much, Gretchen. You raised some great points that I just wanted to make sure that we didn't overlook for the audience who is joined with us today. Why is data equity so crucial to eliminating disparities in care? I just wanted to level set before we delve into the conversation.
I would answer perhaps, I would say the data equity, meaning that we are all counted, that the systems that have access to those data incorporate those data into their decision-making processes, whether it's policy, regulation, or clinical practice guidelines. But I'm going to add to that for the National Minority Quality Forum, the issue of disparities, while at certain inflection points in the systems loop, is relative to other population demographics. What's most important is that we're eliminating disparities in access to the application of current science and the creation of new science that is responsive to all patient and population cohorts. So that's a long answer. Thank you.
Thank you so much. iShot, we owe you a debt of gratitude and recognition for your synthesis of OMB Statistical Policy Directive 15 with such precise policy acumen. So we are excited to turn the floor over to you so that you can help the audience understand the historic significance of this work.
Thanks, Courtney. Hello, everyone. Nice to be here with you all today. So last year, in March of 28th, the OMB released the Statistical Policy Directive number 15, a revision of that, and it had not been updated since 1997. So almost 30 years of not having an updated standards on race and ethnicity data collection. So this revision was very, very unprecedented because, as Gretchen mentioned, it allowed for multiple groups and populations to no longer be invisible. So some of the things that are included in this revision, the race and ethnicity question are now combined and also allow for multiple responses. There are 7 minimum categories for data and race ethnicity. And to note, they added the Middle Eastern and North Africa, or also known as MENA, category as a minimum reporting category, which is separate and distinct from the white category. Previously, they were both combined, which led to the MENA population to be invisible because of their grouping with the white category. They also updated terminology such as removing the use of majority and minority to describe race and ethnicity categories. And then OMB laid out some requirements for the implementation of the revision, including having them be implemented in all reporting and record keeping by March 2029, and also required each agency to create an action plan on race and ethnicity data within 18 months of the revision being released. So that is September of this year. OMB also required that the agencies make these plans public by publishing them on their websites. And then it also established an interagency committee on race and ethnicity statistical standards that review these data categories on a 10-year cycle and also include opportunities for public input. This is really important because data is foundational to understanding disparities and to measure our progress in eliminating them. A lack of standards, a lack of complete data, and a lack of protocols around gathering data gets in the way of us achieving health equity. And these revisions will allow the federal government to understand how well federal programs address a diverse country. If you could go to the next slide, please. So there have been some challenges that have arisen to SPD 15. Prior to President Trump's inauguration, we were hearing that OMB was going to continue with SPD 15, but since the communications from HHS have been put on hold, we have not heard any updates from HHS specifically on their action plan or OMB. However, there are some things that have occurred through executive action that put SPD 15 in jeopardy. One is the executive order ending radical and wasteful government DEI programs and preferencing. So this was specifically for DEI programs across the federal government. However, organizations such as the Center for Medicare and Medicaid Innovation have decided they are no longer going to be collecting data from payment model participants on race, ethnicity, and preferred language, and also sexual orientation and gender identity. Even though the executive order does not specifically call out data and data collection, this points to how broadly the executive order is being applied to anything that has to do with race and ethnicity or sexual orientation and gender identity. Similarly, the Defending Women from Gender Ideology Extremism executive order also caused the Centers for Medicare and Medicaid Services, also known as CMS, to remove the voluntary SOGI questions from Medicare enrollment forms. So the Biden administration allowed health plans to include these demographic questions on their enrollment forms in order to collect SOGI data on those that are applying for Medicare services or Medicare coverage. But because of this because of this executive order, they have decided that they're no longer going to be allowing the collection of this data, therefore also putting SPD 15 into jeopardy. And then finally, the executive order that really puts into perspective the attack basically on racial and ethnic diversity and equity, as well as sexual orientation and gender identity equity, is the executive order that rescinds a number of President Biden's executive orders on equity. It rescinds 29 of Biden's executive orders on equity that span advancing racial equity, Asian American, Native Hawaiian, Pacific Islander communities, Black American and African diaspora community, the Latino and Hispanic community, the LGBTQIA plus community, and the Native American community. So this shows that SPD 15 is in jeopardy. We haven't heard that SPD 15 is going to move backwards or anything of that nature, but this is something to consider as different organizations strategize on how they're going to continue to advocate for data equity. Next slide, please. So this slide just shows that with BCDSA, data leadership is one of our pillars for our health strategy, and we're going to continue to advocate for data equity. So with the work with NMQF and the other members of the coalition, we are still going to be advocating for data equity, REL and SOGI data, because of how important it is to addressing health equity. So with that, I'll turn it over to Courtney.
Thank you so much, Aisha. That was critical information and so timely. I know there was a comment in the chat that referenced disability. So I just wanted to make sure that we level set what SPD 15 actually addressed versus what we, as a part of the Data Equity Coalition, advocate for and advocated for in terms of inclusion in SPD. So Aisha, maybe you could just clarify the parameters of, one more time, of SPD 15, and that our advocacy extended beyond the actual jurisdictional authority that OMB had
Yes.
had issued.
So OMB SPD 15 is only focused on race and ethnicity data collection standards. They are not focused on preferred language, sexual orientation, gender identity, or disability. However, the Data Equity Coalition is advocating for standards beyond race and ethnicity to include language, SOGI, disability, and other components of data collection that would advance health equity. So, for example, last year, BCBSA held a meeting with ASPE, who was working on the HHS action plan for OMB, to discuss using SPD 15 as the baseline and going above that to include standards for SOGI data. So that is something that we are going to continue to advocate for, along with the race and ethnicity data collection categories.
Thank you so much. Such critical information. The minimum standard is SPD 15. So we're encouraging everyone who is viewing this webinar just to make sure this is the minimum standard. We want to go far beyond the minimum to ensure the visibility. And I love the fact, Aisha, that you used making individuals visible. We're trying to eradicate invisibility as it relates to data collection and research. So thank you so much. We have a rich discussion that's going to emerge from this presentation. Jenny, the Urban Institute recently hosted a webinar that was fabulous, using demographic data to advance health equity. I wanted to know if you could just share some of the key highlights, the key takeaways from that presentation, and address how research can help to inform the data collection process around addressing inclusivity and representation.
Thanks, Courtney. And I'll start by saying thanks for including me in this important conversation. And I'll try to share some of the great insights from that panel, and I'll drop that link in the chat as well so folks can see it. And also, you know, we at Urban have been doing a lot of research on data equity, specifically regarding race and ethnicity data over recent years. I'll say a lot of these views are mine and shouldn't be attributed to Urban, but we'll be happy to share a lot of those resources as well. So the webinar that you mentioned was part of a series of events and publications commemorating the 20th anniversary of the landmark report, Unequal Treatment. And that report showed back then the lack of standardized and system-wide collection of data on race and ethnicity as a barrier, and many of those challenges remain today. So just thinking in terms of research, you know, there are a lot of places that researchers can get race and ethnicity data to look at health equity. From coverage applications from health plans and things like that. But in terms of making sure the data are inclusive and representative, some of the key things that have emerged are that it's important for people to see their identities in the categories that are provided. They're not going to want to respond if they don't see those identities. That's one of the reasons the MENA category is so essential, as Aisha mentioned. People should self-report. The self-reporting should be voluntary. It shouldn't be the case that someone looks at you in a doctor's office and writes down what race they think you are. It should be your own identity. It's important that the categories are disaggregated, that people can select multiple categories. And in terms of research, we do need consistency over time or the ability to crosswalk and monitor things. So a lot of those best practices really were incorporated in SPD 15. But then ultimately, research isn't just about identifying the inequities. I think it's important to keep in mind what we're trying to do is have the field use the data we find on inequities to change how healthcare is delivered and design interventions to reduce those inequities. And so that step doesn't just involve researchers, but health plans, states, providers, all these other groups as well.
Thanks, Jenny. And this question actually is for the group as a whole, because I wanted to just make sure that we were addressing how research can be used as a tool to inform policy decision making, so that when we see retraction, such as what is happening right now, that iShot did such a great job of kind of overview for us, how can we work collectively to make sure that there is advocacy to ensure that data representation remains at the forefront of the research agenda from a policy perspective? And this is for everyone. So Jenny, I know that you just, spoke to it a little bit, but just wanted to make sure. Yes, Guadalupe, please.
First of all, good afternoon, everybody, and I'm happy that so many people have registered for this important kind of session. I just want to back up a little bit in terms of SPD 15, and I was looking at the law, right? And I think we need to recognize that the president cannot override SPD 15. This is a congressional legislative mandate, and Congress is the sole authority that has the ability to change the law. So I just want to make that a point that everybody should recognize that. And getting back in terms of, from my perspective, if you look at clinical trials, you look at Blacks, Latinos, Native Americans, right? We are so underrepresented in terms of patient engagement, right? And besides that, we are severely represented as clinical investigators, right? And we need the data to kind of support, to make the case to engage more patients in clinical trials. We need the data to show the case that there is a tremendous workforce shortage among, again, Blacks, Latino, and Native Americans, and other populations that are not represented in the research clinical trial space. So to me, it's data. We need the data to make the case. If we don't have the data, it's very hard to make the case. And if government does not collect the data, FDA, et cetera, it puts us out there, in a space that it's an unknown space if we don't have the data. So.
Thank you, Guadalupe. And iShot, I think Guadalupe raised a really good point, and this may just dial back a little bit to what you were highlighting for us. Can we just make the distinction for the audience between an executive order impact on SPD 15 and a regulatory change, update, alteration to SPD 15, like what occurred last March? So here we are almost 1 year later.
Yes, thanks, Courtney. So executive orders are usually targeted towards the federal government and the agencies, and it's used to direct what the agencies are supposed to be doing in alignment with the president's priorities. But with OMB SPD 15, as Guadalupe mentioned, like that is a congressional directive, and OMB has the authority to update OMB SPD 15 with congressional direction. So that's the difference between them. So it would be I've never seen this before, that OMB walks back something that they've already put out. That would be unprecedented, but I think we also need to remember that a lot of these executive orders that President Trump has signed do not have legal standing. But that also does not mean that people are not going to try to abide by them. For example, the DEI executive order does point to those organizations that have federal contracts and receive federal funding in order to influence the private sector as well. So it's a bit sticky. It's not something that we're used to historically, but it's just something to keep in mind about how to implement the EO and how the EO will have an impact on your specific organization.
Thank you, Aishad. And that's exactly why we need the entire healthcare ecosystem to be highly engaged as advocates for data equity and making sure that the best practices are coming from each of our communities, despite what may be written in an EO. Gretchen, I wanted to see if you could just share a little bit about the Data Equity Coalition that has been co-convened and addressing disability. It came up in the chat in a Q&A, not to forget ableism in the disability community. We have long been advocating for disabilities rights as a part of our work as a collective community. And I believe there was even one of the mini briefs that was done last year specifically addressing disability. So I was going to turn the floor over to you just to provide context that we have not been limited, but we have been the most expansive in our work as a collective community of stakeholders.
Yes, and thank you, Courtney, for asking that question, for posing that question, and helping me with the answer. So I appreciate that. But I think for those who are in the audience today, I would remind you, and Aisha, I think, spoke to it as well, that we approached OMB with a much broader mandate than OMB is currently recognizing. Disabilities is one of those issues that throughout my professional career has surfaced as an issue, and it's challenging for the world, but it was not one that was not part of our priorities. What Courtney spoke to is the need for all of us to remember that advocacy within these organizations can't be limited. We can't allow ourselves to be limited by that to which they retreat, whether it's the kind of retreat that we're seeing now, or simply staying in a safe space. We have a country, we have a system that has based policy and legislation upon the assumed acceptability of exclusion of certain population cohorts, and the Data Equity Coalition, through the lens of race, ethnicity, gender, sexuality, geography, and disabilities, are constantly pushing back on or pushing against, pushing forward. I like that better, pushing forward in terms of helping design a system that recognizes its obligation to work on behalf of all of us and is empowered to do so through legislation and policy. So I'm not quite sure if that answers the question you posed, Courtney, but I think that's the issue. The fact that they say no simply reminds us, highlights for us the areas in which we need to reinforce our efforts to require visibility and action on behalf of, not just counting, but actually taking action on behalf of those populations.
Exclusion at the expense of others in community has been, as Gretchen outlined, a historic truth that has defined the America that we know. And Guadalupe, you have been a beacon of light and hope and consciousness for so many of us across the country with your leadership at the Office of Minority Health historically and your work since that time, and hoping that you can give us some immediate action steps that advocates can take to help to activate some strategies around community impact.
Well, thank you, Courtney. That's a big task. I'll do my best. First of all, I think at the last webinar that I was on, I talked about we're experiencing a government coup, right? And so it's a conflict situation, right? And so we need solutions to address these turbulent times that we're in, right? And I think more importantly, this is to me is a civil rights and a democracy issue, right? So we must preserve those two particular pillars that really impact the lives of all of us. You think about it, not only the folks that we represent. So to me, that's a major priority from my perspective. So proposed solutions, I was thinking about it last night while I was dreaming, right? Sometimes I dream about particular kind of strategies. And I was thinking about the coalition, this coalition can develop like a rapid kind of response PR team, right? And so we can address these, oppressive executive orders that are coming out of the White House. And I think this forum can serve as the war room or the hub for this rapid response team. And I know the issue is about resources. Well, how about using AI as a way to develop the initial kind of messages, right? Because we're in a propaganda kind of war with this administration. They provide misinformation. They don't tell the truth, and on and on and on. But if we do this, at least we can provide some true facts about our positions in terms of, even SPD, but also other health disparity initiatives that are impacting our communities because of these draconian kind of executive kind of orders. And I think the other option would be to use our social media platforms, to convey those kind of messages. And then the other thing is about how do we support boycotts? There's a major boycott coming. I think it's going to happen Monday. That raises the issue of especially these corporations that have backed off on DEI kind of initiatives. We need to make them feel the pain economically, right? And then also, I think, for example, Costco is still in the game. I think Google is still in the game. How do we support their efforts? We need to provide intel to the legal community from our perspective, from researchers, clinicians, et cetera, so they can have the facts when they fight these battles against these executive orders. And then how do we work with other coalitions? Like APHA has about 6 coalitions that deal with health disparities, health equity issues. And then there's a new coalition. It's called Coalition for Trust in Health and Science. They have about 90 members. And I don't know if the forum is a partner. So how do we work with them as allies to keep the momentum going? And then, the Congressional Tri-Caucus, how do we continue to work with them to move the needle, to give them the information they need to support our work? And then We need to reach out to congressional Republican representatives, Cassidy, Susan Collins, Katie Britt from Alabama, because they came out strongly against the NIH 15% reduction, right? And how do we, support their efforts to reinstate or to eliminate that 15% indirect reduction? Because that impacts research, a lot of research centers, and they're feeling the pain because a lot of those states, red states, have these research centers, and they're the economic kind of employment hub of those communities. And lastly, I think working with the Chamber of Commerce, the business sector, they use census data to do market research. They use that data to decide how, what kind of outreach they need to promote their particular products. So, those are just some of my thoughts
That's
that
helpful.
I have. So,
No, thank you. Thank you for that. I wanted to see if we could use those thoughts and focus a little bit on advising how individuals who are in community can help to support protecting and preserving SPD 15 as a part of their future advocacy work. We've been speaking at a federal level. We're speaking at a high level. But if we translate that down to how it impacts individuals in community when they're invisible versus visible, what are we saying to them? And I want to make sure that the audience has an opportunity to place their questions in the Q&A. We will be fielding those questions momentarily, but I do want to make sure that the panel helps to address impact at the community level, local level. Jenny, thank you.
Just wanted to bring in a couple points related to that topic, which I think is so important. One of the things that came up in that webinar of ours that you mentioned was from a federally qualified health center provider who said that more people are declining to share their demographic information in recent weeks than had been before out of fear and mistrust. And so I think one of the things that is going to help move data equity is to really build up that privacy protection, ensure people's confidentiality, and just make sure that people can trust that their data will not be misused by an organization. And, it's a completely reasonable thing for people to be worried, especially historically marginalized groups who think their race and ethnicity identity might result in discrimination or blame for health problems or inappropriate treatment. And so I really think that community organizations can help build that trust. And I'm also thinking back to during the time of widespread vaccination efforts for COVID and how there was a lot of concern about inequities in treatments and vaccine access, and how a lot of different community-based organizations came together to try to support, dispel myths and encourage and support people in getting those vaccines. So just a wide range of organizations, faith-based organizations, social services providers, schools, community health workers, academic institutions, all of those coming together, tapping those to help people find the system more trustworthy and worthy of getting their identities.
No, that the trust element, Jenny, that is absolutely core to community engagement. Wanted to make sure that the audience was clear that the advocacy work for the Data Equity Coalition is 100% bipartisan support for SPD 15. And, I shot Gretchen Guadalupe, Jenny, you can attest to that. SPD 15 has had widespread support across many aspects of healthcare and beyond. We want to ensure that we do not retract, but that we continue to lean in on this very important work stream. The future of representation depends on our ability to do this work as a collective body. Gretchen, just thought I would just open the floor in case you had some lessons learned from the Data Equity Coalition specifically that you think are good pearls of wisdom to share with the audience where we've made progress. I mean, we spoke about disability and ableism. It came back up in the chat that we can't separate racism and ableism because there's intersectional identification. We specifically address intersectionality. That's been a core tenet of the work. And so perhaps that is the mini briefs and a reference to some of the historic written work that we've produced. So Gretchen, I'll just maybe give you space to share a little bit about that.
Thank you. And I think I'm in the process of agreeing with everyone. If I recall, and Aishat or Courtney, correct me, SPD 15 does not apply to the states. It's only applies to funding and work through the federal government. Is that correct? Okay. So as I'm taking your head nod as yes, but I'll verify and get back to you. Okay. I think what's important for creating more engagement, more empowered engagement on this conversation about data equity is the why. Yes, I'm going to say again, not just to be counted, but to be counted to what end, for what purpose? What are the metrics of success, the outputs associated with being counted and visible? But also assuring that in the communities about which we are concerned, we need to make sure that their state laws and regulations enable and advance this same conversation. And I think that's the Data Equity Coalition has begun to have those conversations. But if I recall, the fact that the police departments in the different states are not held to the same data collection standards as SPD 15. That's a direction in which we can move. And I don't mean the police as a negative. I mean the police sort of as literally an enabling force that helps people become more visible. So that's, I guess, one thing. And the other is, as we move forward, as what I hope is more engagement from those who are in the audience for this webinar, the fact that this is not a linear conversation,
Right.
that it is, it's not hierarchical. While we're having this conversation at the federal level, there are conversations that can also and must also occur at the state level and the community level with empowered individuals who need to be made aware of what's required and what is not, and then receive some assistance in developing plans of action to address those issues, whether it's sort of Guadalupe's type of action, but to make sure that people understand what the system does do, must do, but also can do or should do as we move this forward. So I hope that's responsive to what
that
you
is
asked.
responsive. And we had a question that came up in the chat. And Guadalupe, I'm going to see if you can help to address the answer for this. I'm going to read the question out loud and then turn it over to you for the initial response. How do we balance ensuring individuals and groups' identity are visible versus identifiable when reporting and disseminating disaggregated data? And the remark after was especially alongside qualitative data, where the risk of identification, especially on controversial topics, remains high. And so Guadalupe, I was going to turn it over to you, and I was hoping that you might also be able to incorporate the importance of linguistic advocacy and inclusion in your comments and response, because language, I want to make sure that we do not overlook in this multi-ethnic nation that we live in.
Okay. I'll tell you what, can you hear me?
Yes, I can hear you. Yes, yes, I can hear you.
I'll take the language one
Okay,
first.
okay.
I think the second one is a little bit more complex. Not to say that I won't try to answer it.
Okay.
You know, language, LEP, limited English minority populations, or whatever we want to call them. I mean, it is a big issue because we are a country of immigrants, and people just think about folks coming from, the southern border, but we got folks coming from Africa, Middle East, and then there's different even dialects. Let me just give you an example in terms of Mexico. Mexico has a very large indigenous population in Chiapas, Oaxaca, and some of them don't speak Spanish. and a lot of healthcare providers, let's say, when those folks arrive here, they're all confused, right? And there's limited number of interpreters, not translators. People get confused between translation and interpreters, right? And that's a major issue. So to me, it shows the importance of collecting that kind of data in terms of what is your primary language when you go to a care provider, right? Because I mean, that data will start showing trends or giving you an indication in terms of what you need to do to address those language kind of barriers or issues that are confronted by healthcare providers, but also even from patients that if they can't communicate what's wrong with them for themselves or their child or relatives, then there's going to be a lot of misdiagnosis, etc. And I think that to me, I used to work in the disabilities field back in the 80s in California, and that was a big issue because data was not being collected on folks with disabilities, right? And to this point right now, I think the way this coalition is trying to address the inclusion, right, of disabilities or LGBT kind of issue is so important because we can't disregard those populations. We can't disregard their particular healthcare needs, right? And because we need to address disparities that affect those populations, right? So to me, it's important to be comprehensive, right? And also, how do we sell it? How do we market it? How do we promote the inclusivity of having more data versus limited data? And I'll use one more analogy. All these high-tech companies, they're collecting so much data on us. Why? Because they're developing profile on us, right? And I think in that data is being collected all over the country, especially like in California or even here in Virginia, Northern Virginia, the data centers, you name it.
Yeah.
So the data is being collected even if we don't even know that it's being collected, but it's being used by companies to look at our buying habits, even to look at our health status, because they're selling these, gadgets that can monitor, how much we walk, how much we run, the type of foods we eat, our weight, etc. So the data is being collected regardless if we think it's not being collected.
All the time, right?
So to me, it's, I'm more of a big picture, collecting much data, but making sure that that data is not misused and that we have
data integrity.
Right,
Yes.
that we have the data safeguards in place
Yes.
because that data can be misused and we've got to be very careful about that. So
thank you, Guadalupe. Jenny had her hand up. Jenny, please chime in here.
I just wanted to also say that I'm sharing a report we did where we were able to really disaggregate groups of Asian American, Native Hawaiian, and Pacific Islander adults and looking specifically at language. And so just wanted to bring these 2 points together that, we were able to identify subgroups of the AAPI population that are often ignored because they're smaller demographic groups, but those are often the groups that have a lot of people who speak other languages and really might be disadvantaged if those language needs are not met. And so to me, that shows really the importance of getting disaggregation. I also wanted to, your question about trust. I think one of the ways that we can build trust in sharing data is to bring the research back to the communities who contribute to it. So helping people see, okay, I shared my identity and maybe I had concerns about how it would be used, but I actually see now how that was helped develop an intervention that improved things in the community. And I just think that that can be really key role for community organizations, researchers, and all of us in the system.
Yeah.
Thank you.
Courtney, can I just add one more thing?
Yeah.
Jenny's comments. When we talk about trust, right? And I also look at it from a workforce kind of perspective, because if you don't have, and COVID really showed the need to have trusted messengers. So let's say if we don't have trusted researchers that look like us, you're not winning the battle. You know, and not to say that there aren't good people out there that are researchers and it can be trusted messengers, but I think we got to really push the envelope to get more of our people into research, evaluators, etc. And then when people, like even federally qualified health centers, when people see providers, nurses, doctors, dietitians, etc., that look like us, the response is a lot better.
Yes.
And the evidence shows in terms when you have patient-provider concordance, it leads to better health outcomes. And to me, I like to say, if you have trusted messengers that represent us, I think there'll be better avenues to collect the data,
Yes.
to develop the right interventions for our people.
No, I appreciate that. iShot, your hand was up, and we have one question that I do want to get to that's in the chat before we do our final thought.
Thanks, Courtney. I'm just going off of both what Jenny and Guadalupe said. In order to have trust, there needs to be transparency about why you're using the data, why you're collecting the data, what you're using it for, and how it's going to benefit the population that you're collecting the data from. So our health plans have solicited like community-based organizations to help them go into these communities and community health workers to share like, this is why we are collecting this data. This is what we're using it for. And then going back to them afterwards, as Jenny said, to say like, this is what your data led to. This is how we're using it to help you. I think that's really important, along with advocacy and just education overall about why these standards are needed, why certain populations feel like they're invisible, and how these standards would allow them to be visible in the data, and then also ensuring them that their data is going to be private, that it's disaggregated, that no one can pinpoint them based on what they have given. And health plans do a really good job of disaggregating that data so that you can't look at one data set and see who contributed to that. Either their thoughts on something or the programs or anything like that. So I think that's really important, especially the education piece.
Thank you so much. That is critical, and it leads to this last question. There's an individual who asked, or who shared, that she's serving individuals on dialysis and finding it difficult to keep up with the rapid attacks, the changes that are happening federally and on the state level, and wanted some suggestions on who to follow and subscribe to keep up with the information. I wanted to acknowledge that question. The Data Equity Coalition is going to continue to post the resources. Jenny Haley from Urban Institute put a number of links in the chat. We will take those links that were provided in the chat and we will cross-post those on the Data Equity Coalition website. We have a resource tab there. So that will help to continue to address some of this rapid fire every day. You're getting bombarded with information and help to distill truth versus fact and the importance of the data. With that, I'm going to go around quickly, just asking each of you for a final thought. What is the key takeaway that you want the audience to glean from this conversation? If you could do it in 60 seconds, we would be most appreciative. Jenny.
The big challenge. I'll bring up two things very quickly. One is that institutions can keep going forward with their own data standards updates, even if things change on the federal side, but that will take leadership in different institutions really committed to health equity and maintaining that focus, but committing the resources that are needed to really make those changes. The other thing we haven't talked about today is that systems work, the data infrastructure that are needed to implement the changes and the resources that requires, the training, and ensuring that different entities are making their changes to be interoperable across different organizations so that data can be shared and used and compared across different organizations.
Thank you. Guadalupe, do you want me to show your visual for your final thought?
Sure, why not?
Okay. Guadalupe had a visual for his final thought that he wanted us to share. And there it is. That is your final thought. You want to just give us a little.
So I'm thinking about how the United Farm Workers used, well, no, they boycotted. They pushed the boycott agenda, right, to get the growers to come to the table and negotiate, union rights, union benefits, etc. And to me, this is so important right now to join other entities that are having boycotts, economic boycotts, to make change, to push the levers that can, I guess, address the disparities that affect our people, not only health, but economic disparities. And since this is Black History Month, I am a product of the civil rights movement. I wouldn't be here because of individuals like Martin Luther King, John Lewis, Fannie Lou Hamer, Rosa Parks, Cesar Chavez, et cetera, and many other individuals who made sacrifices to pave the way for me and all of us who are probably in this talk.
Yes.
So to me, this is a moment in history where we must come together collectively and take a stand for our human rights, for health equity as Americans and people of this country. So
thank you.
Yes, we can. Sí se puede.
Sí se puede. Thank you for acknowledging the farm workers' justice movement. I shot in 10 seconds. Final thought.
Thanks, Courtney. I just want to say, despite everything that's going on, we shouldn't lose hope. We're all doing good, mission-driven work that impacts millions of people. And as advocates, we need to be strategic about how we're going to move forward to protect the communities that we serve. And that requires perseverance and creativity. So if we just focus on the goals that we are aiming to achieve, even if our language that we use or the tactics that we employ changes, that from what we have traditionally done, we are still focused on our goal of advancing and achieving health equity. So that's just what I want to leave everyone with today.
Appreciate that, Gretchen. And
quickly, I would say that all empowered sectors should focus on saying yes rather than why not. Okay. Absolutely, the data inform those conversations, but I'm encouraging everyone to assess whether what we define as weaknesses, for example, the trust issue that has been surfacing for decades now, how is that really interfering with your ability to move forward, with your commitment and ability to move forward on behalf of those populations? Thank you, Courtney.
Thank you. We want to make sure that everyone who watches this webinar, this broadcast, those live, and who will look at it later, that we are here to make sure that you are seen, that you are represented, and that data drives conscious decision-making to dismantle disparities in healthcare. Data drives conscious decision-making to dismantle disparities in healthcare. We thank you as a collective body. Please continue to follow the Data Equity Coalition. Gratitude to the National Minority Equality Forum for providing us with this platform, and to this esteemed panel. This is just one of many dialogues that we will have this year to continue to protect and preserve Statistical Policy Directive 15. If we did not get to your question, we will as a post follow-up to this call. To Jenny, Guadalupe, Aishat, Gretchen, and to all of the members of the Data Equity Coalition, thank you so much for your time today.